Hey everybody, I am joined here today with Dr. Sophia Stocks at Arizona Foot and Wound Specialists. You can find them at azfootandwound.com. And so we're here to talk about some of the most common types of pain and wounds that patients experience and the treatments that she offers at her practice. So Doctor, thanks so much for joining us today. Really appreciate it.
Absolutely.
Yeah, and I wanted to just kick things off by asking about your experience working in the medical field and
Mhm.
your experience with wound care specifically.
Awesome. So I graduated podiatry school in 2017. Yes, 2017. And I did a 3-year residency at the Carl T. Hayden Phoenix VA Hospital where I worked with veterans. And that's where my exposure to wound care started to thrive. And when I got out, I ended up purchasing my practice a couple of months after graduating residency. So here I have my own practice. I deal with a lot of patients of all ages, children, all the way to geriatrics, wounds, ulcers, sports, injuries, and pediatric cases.
Gotcha. And was there anything that really drew you towards working in that specific space, or was it just wanting to be able to help those patients?
So I personally went through 6 different foot surgeries myself growing up, and my interactions with various podiatrists really introduced me to the field. They absolutely love what they did, and what I liked was whenever you walk into a podiatry practice, most patients walk out improved, educated, and you're not just waiting over months or years for pills to take place or starting a diet plan. A lot of things that we do are hands-on, they're injections or manipulations, they're devices or direct for wounds like debriding an ulcer or a wound in order to have patients see direct improvements right before their eyes.
Yeah, I could definitely see that being rewarding. And what are some of the most common types of wounds that you see in your practice? And can you explain kind of the difference between those?
Mhm. So, the most common type that patients will usually come to a wound care center or a practice that handles wounds would be a diabetic foot ulcer. And those usually begin with patients who develop lack of sensation in their feet and they're putting a lot of pressure on certain parts of their feet, which causes a breakdown of the skin, sometimes callus formation. And that callus, for most patients like you and I, when we develop a callus, it's tender. We stay off of the foot or we'll try to shave down a callus. Change our shoe gear, and then usually that gets rid of the callus. For diabetic patients who have uncontrolled diabetes, usually it leads to lack of sensation in the feet. Once your nerves begin to kind of die off or act differently, they can't sense pressure or sharp pain the same, and they keep walking through it. That callus then acts like a pebble or a rock in the shoe, which starts to eat at the deeper layers in the foot, which can lead to ulceration, breakdown of skin, ultimately a portal of entry for bacteria, fungus, viruses, for infection, which then untouched or untreated leads to infection, possibly amputations, and other systemic difficulties.
Gotcha. And so are those diabetic patients the most at risk for these wounds, or are there other patients?
Yes. So diabetic patients, number one, because they have the neuropathy or the lack of sensation. Next up would have to be patients with idiopathic neuropathy or just a lack of sensation in the feet. And it doesn't necessarily have to be a diabetic patient. If you were exposed to Agent Orange or if you have patients who have suffered low back injuries or injuries in your spinal column that can lead to lack of sensation in the feet, your feet are like a diabetic patient's feet with neuropathy. So, any type of disease or lack of certain vitamins, minerals that can lead to a decreased nerve function in the feet can also lead to breakdown of the skin down there and lack of awareness.
Gotcha. And
Mhm.
is there any type of like preventative care, anything that patients can do to try to avoid getting those type of wounds?
Absolutely. So whether you're sensate and you can feel everything on the bottom of your feet, or if you're neuropathic, getting into a podiatry office is very important. Having someone check your feet, looking at the pressure points, having any type of calluses on the bottom of your feet or your toes, that is abnormal. Just like we don't have calluses on the face, we don't walk on our face, we should not expect to have calluses on the bottom of our feet.
Hmm.
So calluses are the beginning signs of increased trauma to an area. You're overstimulating your epidermal cells. You're having those DNA in those cells replicate and make the skin thicker, which leads to more pathology. So how do you address that when you come to a podiatrist? I look at your pressure points. I take an X-ray. We look at bony alignments, which leads to breakdown of the skin under certain bony prominences of the foot. You want to redirect the forces underneath the foot, realign the foot to optimize function biomechanics so that patients can minimize breakdown of skin, minimize formation of calluses, but also this helps them in the long run because think about your feet as the foundation of a home. If your foundation of your house is crooked or not aligned well, then you're going to have issues in your second story, third story, fourth story, which might show up as cracks, leaning of a home. Same thing, patients can suffer knee pain, unequal wear and tear of your cartilage in your knees. You can have rotational changes to your hip and therefore tightening on your low back muscles, and then scoliosis up higher. Getting your feet adjusted and assessed from the foundation, supporting it properly, then leads to less wear and tear of the structures above.
That makes sense. And I think that's a good point about the calluses too, because I think a lot of patients probably think those are just normal and that it's probably not something
Mhm.
they really need to be concerned about.
Yeah, so sometimes patients come in, they think it's a callus, and I'll even catch wart formation under the feet. So patients who develop a wart, usually you'll have to have a puncture wound or a constant friction, abrasive changes to the skin where you have a break to your barrier, then the HPV virus has a chance in order to invade into the skin and then set up shop. It's really good to get checked out just so you can differentiate, because a wart is quite contagious. If you're treating it, touching it with your hands, it can transmit, or if you have a spouse, you can give it to them. And if it's truly a callus, you want to address that pressure point.
Definitely.
Mhm.
And for those patients that do need the wound care, what type of treatments do you offer for them?
So whenever patients come in for wound care, it could be a various types of wounds. Like I said, diabetic wounds, neuropathic wounds. Some people, they have lack of blood flow or arterial ulcers. So if they're having clogs in their blood vessels from the aorta down to the legs, you have to get that checked out. Having a podiatrist coming in and just checking pulses, being able to see if you're able to palpate the pulsation of the blood flow in the feet is really important. If not, you take out a Doppler, you listen to the quality of the blood flow in the feet. If you don't have good flow from the heart, delivering oxygenated blood and nutrition down to the feet, you can't expect wounds to heal. Just I tell patients, think about me as I'm trying to groom a tree or a plant. I can groom it all day long. I can give it fertilizer. If you don't equip that tree or that plant with water resources, it's not going to thrive. So just getting to a podiatrist or a specialist that can make sure that you have the good vascular flow is number one. And then number two, we already discussed, making sure to offload pressure points, either putting them in better orthotics, a boot, a cast, a knee scooter, or telling patients to get off of their feet in a wheelchair. And then you can also use different either biologics, stem cells, wound care products, antiseptics to make sure that the ulcer is kept clean is very important. A lot of wounds are quite dirty, and patients are not aware they're not supposed to be showering and getting their ulcers wet. Whenever you shower and you're stepping on your wound, everything that's in your hair, your armpits, your body, that starts to flow down with gravity, and now you're inoculating an ulcer that's meant to be kept clean and as sterile as possible. So just being educated on how to keep the wound cleaned, keeping it vascularized with the right amount of nutrition, that's like 90% of the battle, and then offloading it.
And you mentioned some of those treatments are, stem cells or some different treatments that you can do for those. Can you talk
Mm-hmm.
about those?
Yeah, so I used to have a lot of like stem cell products, placental or amniotic grafts in my office, but now I like partner up with my friends who have a little wound care clinic where it's easier to just um, kind of refer to them or siphon to them, and they also apply those products to the patients. I'm a smaller clinic. I have 3 rooms, so we try to be efficient. Most ulcers, when patients come to me, I expect to heal them within 3 to 4 weeks. That's my goal. If you're not healing in 3 to 4 weeks, you have major things going on, as in you need to have a vascular doctor involved. You need to check your nutritional status. Your diabetes needs to be under control. Or maybe you could benefit from having amniotic or stem cell products, which will then act like a scaffold to stimulate your own ulcer to heal. And so it's a lot of avenues that patients with wounds have to look at, and getting to the right specialist to get you down and check all those boxes to make sure you optimize and heal is important.
Definitely.
Mhm.
And how often should patients be doing that type of wound care, coming back in
Mhm.
and having those treatments done?
So when patients have ulcers, they come and see me. I usually try to see them 2 to 3 weeks after that for follow-up. If it's a really infected wound and patients, the foot doesn't look very healthy, I want to make sure to get them back within a week after starting them on antibiotics. Imaging is very important. X-rays can show a lot. If you can see erosive changes to the cortex of a bone, where it looks like a cookie bite, that means that you have some invasion of bacteria into the wall of your bone. Then you have a bone infection. You have to target it with special types of antibiotics that can penetrate bone to protect it. And also, you want to culture the wound to make sure you know what kind of bacteria is growing in that wound. or if they have soft tissue gas or some type of a necrotizing fasciitis that's really emergent, x-rays are important because you can see those little gas bubbles in your x-ray, which, they got to get to the OR. They have to be treated immediately for surgical debridement or opening it up.
Definitely.
Mhm.
Yeah, those are the questions that I had. Was there any last advice that you have for a patient if they're maybe struggling with a wound and they're not sure what that first step should be?
Yeah, so if you have an ulcer or a wound, you definitely want to get in to see a podiatrist, and make sure your podiatrist has an x-ray in the office. Stay off of that foot. You don't want to be putting weight on it. The more that you break down the skin that has an ulcer or you introduce it to filth and bacteria, that wound is going to be caked up and it's going to have a higher failure rate. Time is of the essence. The sooner you work on a wound, the sooner that wound hopefully gets its nutrition and is able to rebound and heal. The longer you wait, the more infected it is, um, the more other structures are involved, such as bone, blood vessels, muscles. Then, even if you treat the ulcer, you have to surgically go in and cut away at what's decayed. So, in order to avoid that, if you even have red spots, raw spots, calluses, get into a podiatrist. And once I heal a patient, I want to see them maybe in about 3 weeks just to make sure the skin stays closed. And then after that, every 9 weeks, I perform routine foot care where we try to trim down the calluses or we do nails for patients because if they're insensate, they're cutting their own toenails. I've had patients cut off the end of their toes because they have no sensation. That leads to infection and more wounds and therefore amputations. So just getting in and having the right specialists at play to protect your feet. My goal is only to see you for routine foot care every 9 weeks. Yep.
Definitely. No, it's good to know that that's the process of it and making sure that those patients come back in for those routine checkups as well.
Awesome. Well, thank you. Any other questions you have for me?
No, that'll be it. So yeah, I appreciate you taking the time to talk with us and share the education on that.
Absolutely. Thank you.
All right, well, thanks again.